starting with serous tumors of the ovary. So they occur in about 50% of ovarian epithelial tumors. Okay, so 70% of them are borderline or benign, and 30% are malignant. So serous carcinomas, they occur later in life. Benign and border ones, they occur in 20 to 45 years of age. So molecular pathogens, see risk factors, basically cystis, it is empty, there is nothing. So nulliparous women, and when the gonads themselves are not there, so gonadal dysgenesis, so BRCA1 and BRCA2 mutations, family history is a risk factor, and oral contraceptives, it reduces the risk. So again, serous carcinoma, you have low grade and high grade. So low grade, there are KRAS mutations, and high grade, you have TP53 mutations. So morphology, basically, so the it appears as smooth and glistening. It consists of one or more thin-walled cysts. The lumen is filled with clear watery serous fluid. The cut section, again, the internal surface is smooth and shining. And then there are small papillae that project into the cavity. Bilaterality is common in case of benign, whereas borderline tumors, the cystic cavities are filled with dense and closely packed cauliflower-like papillary projections. There are more papillae. And then in malignant serous adenocarcinoma, there is a mixture of solid and cystic areas with large solid papillary areas, and there are areas of hemorrhage and necrosis. And addition to adjacent structures is there. In microscopy, so the cysts are lined. Okay, you have papillae. Okay, if this is the cyst, you have papillae like this, and they are lined by non-stratified or stratified cuboidal or columnar epithelial cells. Okay, and cilia may be present. There are papillae with a fibrovascular core, and within the papillae, samoma bodies may be present. They are dystrophic calcified tumor cells. And borderline tumors, basically, you can see multi-layering. Okay, instead of a single layer of cuboidal or columnar cells, you can have multi-layering, and you can have budding or cellular tufting. So basically, these tumor cells, they are stroma free, and then they get detached and they float into the lumen of the cyst, and there could be nuclear atypia, increased mitotic activity, and absence of stromal invasion. There may be complex papillae and samoma bodies. Malignant, so serous carcinoma based on molecular changes is classified as low grade or high grade. So low grade, there's a variety of architectural patterns to be seen. So you can see single cells and small nests of irregular shape infiltrating the stroma and micropapillae. And high grade serous carcinomas, so you can see frank effacement or widespread invasion of the underlying stroma, and there is marked nuclear atypia, pleomorphism, hyperchromatic nuclei, atypical mitotic figures, and samoma bodies especially, and bizarre form of multinucleation. So here you can see there are papillae lined by cuboidal or columnar cells. Okay, and again you can see samoma bodies. So spread, there is local spread. So umbilical metastasis is called Sister Joseph's nodule. It can spread to the contralateral ovary, etc. Lymphatic spread to the para-aortic and pelvic lymph nodes, and hematogenous spread to the liver and the lung. Moving on to mucinous tumors, they are less common than serous tumors and constitute about 30% of all ovarian neoplasms. 80% are benign and 15% are malignant. They occur during middle adult life. So risk factors, you have smoking and KRAS mutations. So general features, so they're larger than serous tumors. They're multiloculated, and the locules are smaller, and they're filled with sticky gelatinous mucinous fluid rich in glycoproteins. And bilaterality is less, and surface involvement is rare. So gross, you have benign mucinous cystadenoma. So it is multilocular. There are thin-walled cysts with smooth external surface, and there is sticky semi-solid mucinous glycoprotein-rich material. And borderline, it is similar to mucinous cystadenoma and carcinoma. So basically, there are additional solid regions, and there is a lining of tall columnar epithelial cells with apical mucin, and they lack cilia. And there are solid areas, right? So they show areas of hemorrhage and necrosis. So microscopy, you can see many cysts and glands for the mucin. So they're lined by simple non-stratified, okay, single layers, so non-ciliated, tall columnar mucinous cells, okay, with apical mucin and basally situated nuclei. This epithelium resembles a gastric foveolar type epithelium, and borderline mucinous cystadenoma. So all the papillary projections are there. They are less conspicuous. Again, you can see budding or cellular tufting, mild nuclear atypia, increased mitotic activity, etc. There is absence of stromal invasion, whereas carcinoma, there is stromal invasion, there is atypia, cell stratification, loss of gland architecture, necrosis, etc. And again, pseudomyxoma peritonei. So you can see peritoneal implants and local invasion into neighboring structures like the bowel, abdominal wall, etc. So pseudomyxoma peritonei, it is characterized by extensive mucinous ascites and cystic epithelial implants on the peritoneal surface. The abdomen is filled with tenacious semi-solid mucin. Mostly it is caused by metastatic spread of tumors in the GIT, especially the appendix. So peritoneal adhesions can cause intestinal obstruction. It can develop due to mucinous tumor of the appendix with secondary ovarian and peritoneal spread, and metastasis to distant organs are infrequent. Endometrioid tumors, they show tubular glands resembling the endometrium, benign or malignant endometrium. Benign and borderline endometrioid tumors are rare, but endometrioid carcinomas, they account for approximately 20% of all ovarian cancers. So 15 to 20% of these, they coexist with endometriosis, whereas 15 to 30% are accompanied by carcinoma endometrium. So molecular changes, you have frequent mutations in PTEN, PI3K, CA, and then ARID1A and CRAS, okay, and also beta-catenin. So morphology, most are solid and exhibit necrotic areas, but some may show combination of solid and cystic areas. In the previous two, mucinous and serous adenocarcinoma, you had cysts, but this is usually solid. They exhibit necrotic and hemorrhagic areas, but some are a combination. Next, you can see a glandular patterns resembling endometrial origin in the microscopy. And Brenner's tumor, so basically Brenner, remember runner, okay, runner, they take a lot of coffee, they're always in a transitional zone. So coffee bean nuclei, so there is nuclear grooving, and also transitional type epithelium, so nests of bland epithelial cells, transitional cells separated by fibrous stroma. And gross, okay, coffee bean is solid, right? So it is predominantly solid or rarely cystic, and it is usually unilateral. So Brenner's tumors, they consist of nests of bland transitional type of cells which resemble urothelial cells within a fibromatous stroma. They are uncommon tumors and most are benign. Next, clinical presentation of surface epithelial tumors of the ovary. They are mostly asymptomatic. They may be unilateral or bilateral. Most tumors are non-functional. The most common symptoms are lower abdominal pain, vaginal bleeding, and due to compression, you can have symptoms such as urinary frequency, dysuria, GI symptoms, etc. Most malignant ovarian tumors are detected when they spread outside the ovary. So there is progressive weakness, weight loss, and cachexia, cancer cachexia, massive ascites, and the ascitic fluid may show exfoliated tumors, and there could be metastasis. Regional lymph nodes are often involved. Next, biochemical markers, you have CA125 for ovarian cancer. It is high molecular weight glycoprotein present in the serum of about 80% with serous and endometrioid carcinomas. It is not a reliable marker because it can be elevated with non-specific irritation of the peritoneum, such as with endometriosis and inflammation. And osteopontin is expressed at higher levels in ovarian cancer patients. Moving on to germ cell tumors, so they constitute about 20 to 25% of all ovarian tumors in adults. Most are benign, but in children and young adults, they are malignant. Okay, so teratomas, all benign ovarian teratomas have a karyotype of 46XX. They occur in women. Okay, so ovaries, so 46XX, that's it. Teratomas arise from an ovum after the first meiotic division. They originate from totipotent cells, teratomas, totipotent cells, after the first meiotic division. So the teratoma contains mature or immature cells or tissues representative of more than one germ layer and sometimes all three embryonic layers. So these cells or tissues are arranged in a helter-skelter, disorganized fashion. So classification, you have WHO classification, so mature teratomas with cystic and solid forms, and again immature teratomas and monodermal teratomas which are highly specialized, okay. So mature benign teratomas, they are cystic and they are better known as dermoid cysts. They are usually detected in young women, 46XX, usually in the third decade. So morphology, they are unilocular, thick-walled cystic tumors with a smooth, shiny outer surface. Unilocular, thick-walled, smooth, shiny outer surface. Unilocular. Next, the cut section. The cyst consists of yellow or grey, buttery or cheesy sebaceous material with a variable amount of hair. So cyst is lined by wrinkled epidermis, so as you can see, wrinkled epidermis, and you can see tooth and areas of calcification. And Rokitansky nodules or protuberance, so there are one or more foci of rounded nodular structures covered with hair protruding into the lumen of the cyst, and they are also known as the mammillary body or tubercle and dermoid nipple. It shows greatest variety of tissue types from all three germ layers, and teeth tend to be located in this site, okay. Next, microscopy, they show differentiation along ectodermal line. So here you can see mainly ectodermal, so skin appendages, sebaceous glands, etc. And in most cases, structures from all three germ layers can be identified. So ectoderm, you have skin, you have hair, you have sebaceous glands, and you have neural tissue and glia. Next, mesoderm, you have cartilage, okay, you have fat, etc. And endoderm, you have thyroid, okay, you have gut, etc. So sometimes teratomas may produce infertility and may undergo torsion, which constitutes an acute surgical emergency. So limbic encephalitis may develop as a rare paraneoplastic combination with teratomas containing mature neural tissue. So limbic encephalitis. Next, malignancy in mature cystic teratomas. One of the mature cellular elements may undergo malignant change in about 1% of termites. They can include squamous cell carcinoma, thyroid carcinoma, melanoma, etc. So solid teratoma. Rarely, mature teratoma can be solid with mature tissues derived from 2 or 3 germ layers. Immature malignant teratomas, so they constitute variable amounts of tissue which resemble embryonal and immature fetal tissue. So they are mostly found in prepubertal adolescents and young women. So the tumors are bulky with smooth external surface. Cut section is predominantly solid because it is immature, it is malignant, okay? It is predominantly solid and variegated appearance showing heterogeneous mixture of various tissues. Solid areas may show, see there could be areas of necrosis and hemorrhage because it is predominantly solid, and solid areas may show grossly recognizable immature bone, cartilage, hair, sebaceous material, calcification, etc. Okay, and next, microscopy, you can see varying amounts of immature tissues with some mature tissues derived from 2 or 3 germ layers. You can see immature neuroepithelium such as neuroepithelial rosettes and glia, and again cartilage, bone, muscle, etc. Grading is based on the amount of immature neuroepithelium. So you have struma ovariae, they're monodermal teratomas and somatic type tumors arising from a dermoid cyst. So specialized teratomas are rare and they're composed entirely of one tissue type. So struma ovariae is one such example. It is a cystic lesion. It consists of mature thyroid tissue. It may lead to hyperthyroidism because of hyperfunctionality. Next, ovarian carcinoid. It probably arises from intestinal epithelium in a teratoma and it may be functional and can result in carcinoid syndrome by producing serotonin. And stromal carcinoid, it is a combination of struma ovaria and carcinoma in the same ovary. So dysgerminoma is a malignant germ cell tumor despite the term oma. Okay, it is malignant and it is the ovarian counterpart of seminoma testis. Okay, so it constitutes about 2% of all ovarian cancers. It occurs in the second and third decades. So predisposing factors, see dysgerminoma, dysgenesis of the gonads. Okay, it is one of the risk factors, including pseudohermaphroditism. So most of them, they do not show endocrine function and molecular changes. Obviously, they express OCT3, OCT4 and nanog and also tyrosine kinase KIT receptor. So gross, obviously it is solid and smooth and bosselated and nodular. So solid, firm, round to oval encapsulated tumors. They're smooth, nodular, bosselated. Size varies, and then the cut section, it is soft and fleshy, and it's basically like a white chocolate gem. So this germinoma, white chocolate gem. So inside cut surface, it is soft and fleshy chocolate and also a cream colored white chocolate, and external surface is smooth. It is bosselated. If you take many gems, it appears bosselated, smooth, okay, capsulated, all that. So microscopic patterns, the tumor cells are arranged in sheets, groups, cords or nests because it is malignant, separated by scant fibrostoma. And tumor cells, they resemble PGC's primordial germ cells, so the cells are monotonous and uniform. The cytoplasm, it is abundant, clear to finely granular, glycogen filled. So there are glycogen filled cytoplasm, and again cell membrane is well defined, and nuclei is large and rectangular, and it is centrally placed with fine reticular chromatin and one or more prominent nucleoli, and mitotic figures are numerous. So stroma, it is scant and it is infiltrated with mature lymphocytes. Next, so there could be local spread to the peritoneal cavity, and lymphatic spread, it can spread to the contralateral ovary and retroperitoneal nodes, and blood spread to the lungs. All are malignant and it is highly radiosensitive. Next, endodermal sinus or yolk sac tumor. So sinus, remember sin, so chill out, okay? Chill, so Schiller-Duval bodies, and yolk sac, right? So alpha fetoprotein and alpha-1 antitrypsin, the tumor is rich in them. So it is the second most common malignant tumor of germ cells, and it is originating from differentiation of malignant germ cells along the extraembryonic yolk sac lineage. So it is rich in alpha fetoprotein and alpha-1 antitrypsin, and it is common in children or young women. So gross, it is unilateral and solid, okay? Sinus, single, right? So single ovary, unilateral and solid. And Schiller-Duval bodies, it is a characteristic feature. It is a glomerulus-like structure composed of a central blood vessel and enveloped by germ cells within a space lined by germ cells. And center of that you have a central blood vessel. So it's a glomerulus-like structure. That is a Schiller-Duval body. And next you can see hyaline droplets. So all show prominent intracellular and extracellular past positive hyaline droplets. Some of these may stain for alpha fetoprotein. Next, tumor markers, you have alpha fetoprotein and alpha-1 antitrypsin in tumor cells by immunohistochemistry, and alpha fetoprotein in the serum. It is aggressive and it is a rapidly growing tumor. And finally, non-gestational choriocarcinoma. See, remember, choriocarcinoma. So obviously chorion, it secretes HCG. So it is cytotrophoblast plus syncytiotrophoblast, but there are no villi. and obviously it is chorea, so solid chorea and solid with large areas of hemorrhage and necrosis. So um, here you can see gestational, it is more common of placental origin. Non-gestational, it can be confirmed only in the pre-pubertal girl. Okay, and pure choriocarcinomas of ovary are extremely rare and may coexist with other germ cell tumors. So grows solid with large areas of hemorrhage, and microscopy it has syncytial trophoblast and cytotrophoblast without any villi. Okay, non-placental, no villi. So behavior, it is aggressive. Tumor marker is HCG, high levels of HCG, and prognosis, it is usually fatal because it does not respond to chemotherapy. Other germ cell tumors, you have embryonal carcinoma, which is a highly malignant tumor of primitive embryonal element similar to that of the testes, and mixed germ cell tumors. Sex cord stromal tumors. So ovarian stroma is derived from the sex cords of the embryonic gonad. So this group of tumors is known as sex cord stromal tumors. They are derived into pure sex cord tumors and pure stromal tumors. So hormonal activity, some of these cells normally secrete estrogens or androgens, and the corresponding tumors may be either feminizing, such as granulosa theca cell tumors, or masculinizing, such as Leydig cell tumors. So pure sex cord tumors, you have adult granulosa cell tumor, okay, which is feminizing, okay, but remember adult, right? So they drink coffee. So coffee bean nucleus, elevated elongated nucleus, cleaved, okay, and again coffee bean cell. So the cell is small, it is cuboidal to polygonal to spindle shaped, and adults, they call, right? So call Exner, you see call Exner bodies. So it's a low-grade malignant sex cord stromal tumor composed of granulosa cells, often within a variable number of fibroblasts and theca cells. It is associated with estrogen secretion, that is why it is feminizing in nature, and it occurs in postmenopausal women. So morphology, it is usually unilateral. The cut surface, you can see hormonally active tumors that have a yellow color due to intracellular lipids. So lipid-laden luteinized granulosa cells, lipid-laden luteinized granulosa cells in adult granulosa cell tumor. Lipid-laden, adults are fat, okay. Next, size varies from microscopic foci to large encapsulated cystic masses, solid cystic masses. In microscopy, you can see tumor cells that are small, cuboidal polygonal cells to spindle shaped, and they have a cleaved elongated nucleus. So coffee bean appearance. Growth patterns, you see DIT. So diffuse, insular, so islands of cells, and trabecular, so anastomosing bands of cells, and Kollexner bodies, which are small, distinctive gland-like spaces filled with an acidophilic material, and they appear like immature follicles. They're very useful for diagnosis. Next, stromal component. So you can they contain a variable amount of fibromatous or thecomatous You can see you can use reticulin stain to see reticulin fibers around the nests of tumor cells. So clinical features, they present with postmenopausal bleeding in postmenopausal women, and menorrhagia, metorrhagia, and amenorrhea. And behavior, they are low-grade malignant tumors. Biochemical markers, you can see inhibin, which is secreted by the granulosa cells, and elevated serum and tissue and serum levels of inhibin. They're useful for identifying granulosa tumor and monitoring treated patients. So FOXL2 gene mutations are also seen. Juvenile granulosa cell tumor is a distinctive type. It occurs mainly in children and young adults. And pure stromal tumors, so you have Meigs syndrome, we'll talk about that. So tumors arising from ovarian stroma are only composed of stroma, so fibroblasts, so fibromas, plump spindle cells with lipid droplets are thecomas. Pure thecomas are rare but may be hormonally active. Majority of fibromas and thecomas are benign. So fibroma, it is unilateral in about 90% of cases. It is solid fibrous, okay, spherical or slightly lobulated, encapsulated, hard white gray mass covered by glistening intact ovarian serosa. So microscopy, you can see well differentiated fibroblasts separated by scant collagenous connective tissue. Scant, why? Because it is malignant. Next, clinical features. Malignant, yeah, I don't remember that part. Next, so usually it presents as a pelvic mass, sometimes accompanied by pain, and associated features. So Meigs syndrome, it is a combination of ovarian fibroma plus hydrothorax plus ascites. Mechanism is not known. Ascites is found in 40% of cases when tumors are larger than 6 centimeters in diameter, and uncommonly hydrothorax is seen only on the right side. Fibroma may be found in association with basal cell carcinoma. Next, metastatic tumors. So the source of the primary tumor is from genital tumors such as uterus, fallopian tube, or contralateral ovary, and also extragenital tumors. So carcinomas of the breast, gastrointestinal tract, etc. So gross features which point to metastatic carcinoma are bilateral involvement and multinodularity. So Krukenberg tumor, it was first described by Krukenberg, and it is usually found between 30 to 60 years of age in patients. So sources of primary, so stomach is the most common primary site, and large intestine and breast. So gross. So most are bilateral, moderately enlarged shape of the ovary is maintained. There is a variegated appearance and a solid tumor, so variegated because multilocular appearance. In microscopy, you can see nests of mucin producing signet ring, so breast fat, okay, fat signet ring kind of thing, and mucin producing, so stomach has a mucin lining. So cancer cells surrounded by ovarian stoma. The cells are in ovarian stoma.